So the sulfonylureas are the first group of drugs we're going to talk about for the management of type 2 diabetes. And they actually bind, this is probably the easiest one to remember, they bind to the sulfonylurea receptor, which of course is on those beta pancreatic cells within the, those beta islet pancreatic cells. And when these drugs are bound, these drugs stimulate the release of insulin on that cell. So a lot of people will sometimes think of these drugs as oral insulin. Of course, you know, you can't orally take insulin because your digestive enzymes would degrade it, but the physiologic outcome is pretty similar to taking insulin. From a clinical standpoint, the target population would be patients that have a insulin deficiency, so they have diabetes, of course, but there is some beta cell functionality. Okay, so you can't obviously stimulate the release of insulin from a beta cell if the beta cell is non-responsive. So there has to be some life left in the beta cell in order to achieve this. And from another clinical standpoint, the glucose target is really looking at, you know, kind of the fasting outcome. And so here's a nice kind of summary table that Dr. Prasad has put together in terms of all the different factors that produce hyperglycemia. And of course, there's the pancreas looking at reduced insulin secretion, and this is the site of activity, of course, of our sulfonylureas. There's two classes of drugs. I really want you to focus on the second generations, and you'll see why. The first generations, they're a little bit older, and as the text points out, they're almost archaic. Hardly anyone uses them. The second generation drugs, glyburide, lamipridine, glipizide, these drugs are quite commonly used, and they're 100 to 200 times more potent than the first generation drugs. And so from a hepatic or pharmacokinetic standpoint, they're all hepatically metabolized. Glyburide of those has some active metabolites that have renal elimination, and so patients that have, you know, maybe poor renal functionality might see an increased concentration of those metabolites in the bloodstream, which may or may not contribute to toxicity. In terms of efficacy, they can reduce the fasting plasma glucose by anywhere to from 60 to 70 milligrams per deciliter. And from a clinical management of diabetes, they can reduce A1C by anywhere from 1.5% to 2%. So pretty potent A1C reduction. And that's going to be kind of the theme through this lecture is, you know, how potent are these drugs at reducing A1C, which is kind of like a good marker for kind of long-term management of these patients. And of course, the main two adverse effects include hypoglycemia and weight gain. Okay. Typically, in terms of dosing, and we're not going to really test you on this, but just so you've seen it, you kind of initiate a kind of a lower dose and then you titrate every 1 to 2 weeks, depending on the patient's blood glucose readings and so forth. Of course, they'll be monitoring this at home using a glucometer and so forth. And so and the reason you want to use those lower doses is because, like elderly patients, patients with renal or hepatic dysfunction, are going to need lower doses anyway. And so you titrate appropriately based on blood glucose readings. The maximal effective dose is about 50 to 75% of the stated maximal dose. Okay, and so we know what the maximal dose is. That's published, and so, you know, in order to maximize the effect, you want to go about, you know, half to 3/4 of that. And examples of those specific drugs are given there. And so all this can be found in the dosing guidelines if you happen to take the packet out of the bottle. And so just to kind of compare and contrast, in terms of sulfonylureas, the advantages of them, and I really like how she kind of laid this out, is that they're inexpensive. They offer potent A1C reduction. We said upwards of just shy of 2%. And we have extensive clinical experience in them. The disadvantages, of course, include hypoglycemia and weight gain, which are pretty much found in every drug in this category. There is a very possible cardiovascular disease risk with some of these drugs, and so they are quite potent. And so one of the clinical parameters in terms of justification of these drugs is that you have to kind of beware of these drugs in the elderly. And you also have to kind of be aware of these drugs in patients that have pre-existing cardiovascular disease. Some of those patients just cannot withstand the possible changes in glycemic control, and they have a higher risk of developing hypoglycemia when used on these drugs. But still, you can still find these drugs in older people, just probably more likely at the lower dose. So that's it for the sulfonylureas. Let's take a break.